Anne?
Are we ready? Oh, I was waiting for one. I'm so good. I can tell I went to Catholic school. Everybody. Okay. Good morning. Welcome to the Service to Consumer Subcommittee meeting. Today we are going to go over our agenda, which includes the approval of the minutes, getting a final approval on the our report of services to constituents that included the survey of nearly 500 individuals who voluntarily participated, as well as interviews with DHSS leadership. And so that yielded a tremendous amount of data, as well as research done by members of the committee, such as Rich Gesture and others who went through a painstaking process of obtaining documents and providing that information as well. And from that, we yielded a number of recommendations. And so it's been almost a year. It's been more than a year since this committee has been together. And in what I would like to do, because I do think this might be our final meeting as a formal group before we go to the DHSS full task force, who will be then reviewing all the recommendations. So I just want to recognize the work of each individual here. I want to thank you for the investment of your time, because everyone rolled up their sleeves. They put a lot of time into the results that we're going to get. And I am really pleased with what we accomplished. I think the report, the PowerPoint, the report, and all of the data is a tremendous amount of information and a deep and broad dive into the way services are delivered in health and social services. And I'm really, really proud of this work. And I'm proud of the manner in which it was done, in a spirit of consensus, honoring each other's expertise, as well as passions for how we provide services to those who are most needy in our state. Where is that safety net? Where are the breaks? Where are the fractures, and how we can improve it? And it was in this spirit that we undertook this effort, was in a gap analysis, looking at barriers, looking at obstacles, looking at gaps in services, and then looking at ways in which we can improve it. This was undertaken with the lens of how do we make things better? Where are opportunities for improvement? It was not undertaken in any means to point fingers, be accusatory, or belittle the work, the hard work that is being undertaken by DHSS Secretary Majaric and her leadership team and all of the frontline staff that undertook this work. And so I think that what we accomplished, I'm very proud of. I hope that all of you are. And I think today is really a celebration, if you will, because we are getting to the finish line. Hallelujah. And so I'm really, really happy that we're getting there. And Devana is going to walk through a process with us. And I'm pleased that we had everybody voted. I had Bennett vote early and often on one recommendation, and I apologize for that, Bennett, and giving faulty instructions. A good Chicago Democrat there. You got your priority in. But and so I had to go back in with some people on that. But I really appreciate everybody. I know how busy people are with COVID, with working community. Yvette, your work on vaccinations and getting things out. And so taking this time today, I appreciate how busy everyone is to be here to come to what will be our final recommendations. Before we get to that point, however, I just want to say that give everybody a big hand and celebrate your work. I really want to thank you. At this time, the minutes were provided for our meeting and last meeting. They were shared with you. May I have a motion or any discussion on the minutes or edits to the minutes before we have a motion to accept the minutes?
I move to accept the minutes.
Okay, second.
I second it.
Okay, all in favor?
Aye.
Okay,
Aye.
great. So at this point, what my intention and our intention is that once we get to the final recommendations, a consensus, and walk through the process that Devana has so graciously defined for us, but in a process where you have an opportunity in this consensus mode to recommend that we eliminate any recommendation, we combine any recommendation, or we advocate. But Devana will walk through the votes and the tally of those votes and where the recommendations fell. And I just, so that's what we're going to focus on in this meeting today. Once we get agreement on the 10 top recommendations that we will put into the report, that does not mean the other reports will go away. They will be encompassed into the body of the report. In addition, Richard has taken everybody's comments and created an Excel sheet, and I'm going to share that with everyone after the meeting. We didn't want to do it today because we thought we'd confuse you all, which I've done a good job of sometimes. So we're going to get that out to all of you so that you can see the breadth of all of those, and Richard will probably make comment later on that. But what I'm going to do now is to move to the PowerPoint and just say the corrections were made. Devana, could you bring up the PowerPoint? So the corrections were made in the PowerPoint that we cited the last time relative to the number of respondents. As you refamiliarize everyone, the number of respondents for the survey was 491. We created the slides so they were readable. We put in everybody's names correctly spelt, and we sustain. And in the end, we put in the listed the recommendations. And Devana is going to walk through and take us to the end and facilitate that discussion at this point where we review recommendations. Is everyone comfortable with that, or does anybody have any comments before we go into discussion of recommendations? Okay, Devana, take it away.
Okay, thank you. Good morning, everyone. So as Ann mentioned, we have the recommendations that we're going to be reviewing, and just to point out, throughout our final draft report, we have several different sets of recommendations. We have recommendations from our division director interviews, and we have recommendations from the survey itself. And then we have the overall recommendations, and those are the recommendations that we ask all of the committee members then to go through and rank. And so what I will share is the rankings. You all saw the matrix that that Ann used to tally your votes. You probably can't see it on here, but we took those rankings, we took those votes and then put them in the form of rankings. So I'm just going to advance my slides to the end, and this is the first part of the slides. These are all of the updated slides that kind of walk through the different phases of our work, and then we updated the slides to include all of the revised recommendations that appeared in the final draft report that you have, and there are a total of 21 recommendations. Can everyone see the slides, by the way? Okay. And so the next slide that you see then are the voting results. And so from the matrix of the voting, the tallied scores, we then have a list of the ranks in order of the number of votes that were given. Everyone had 7 votes We had 7 votes because we wanted to be able to end up with some options to create and have discussion about what the final additional priorities or recommendations would be. So based on the raw voting numbers, this is what we ended up with. So the number 1 recommendation, and actually the first 3 had the same number of votes. So number 1, to establish a new Office of Health and Social Equity in the Office of the Governor. I didn't include the entire recommendation because it wouldn't fit on the slide, but you can refer to page in the report. You can see the full listing of the recommendations, but they're also, the full recommendation is also on the slides preceding these. So that's number 1. Number 2 is recommendation number 10, which also received 10 votes, focus on customer service and quality measures of service delivery. Number 3, also with 8 votes, is to divide the Department of Health and Social Services into a Department of Public Health and Department of Human Services, so splitting it into 2 departments. Number 4, the the rank is recommendation 4 to establish a centralized wait list for specific services for each division. Ranking at number 5 is to create a new division of aging and merge the division of adults with disabilities and the visually impaired and the development disability into a single division. So splitting out division of aging and then merging the other 2 divisions into a single division. Ranking at number 6 is addressing job classifications to meet current needs and pay seasonal casual workers a livable wage. At number 7, to implement person-centered services, especially for persons in critical transitions. Number 8 is to create 3 pilot service integration models in each county. And number 9 is on accountability. This is the recommendation on gap analysis, consumer complaints, and quality outcomes that are not consistent. And then number 10, coming in at number 10, all of these last 4 recommendations received 3 votes each. So we included all of them as number 10, and part of our discussion here will be to decide, do we want to include one of these, or we feel more strongly about one of them, or so that's part of our reconciliation process. But getting 3 votes are the following. Recommendation number 7, to address racial disparities and inequities within DHSS and service delivery and in the leadership. Recommendation 15, to conduct a DHSS annual customer satisfaction survey to get feedback from constituents. 19, to create a population health division to monitor technology integration and data analysis. And the last one, number 20, to create a chief data officer position within DHSS to manage the technology and data for divisions. So those are our top 10. So it's really more than 10, but we included the 4 that all got the same tie votes in the last one. And then Ann and I went back and forth a little bit on this when we had tie votes for several of these, and we thought, well, do we make that rank the same, or do we just do 10? And we came out, we'll just do 10. So we had a total of 21 recommendations. So does anyone have any questions or reactions or surprise seeing the recommendations? Okay, so Bennett, yes.
Yeah, I just wanted to share that I was the one who recommended number 16, the 3 pilots. And I did that looking at all the feedback that has been captured by the committee. And I think that looking at I know that we've been looking at the state system, but I think also Delaware has a strong nonprofit. And I guess I was recommending this 3 pilots to integrate the public sector with the private sector based on outcomes that would pull in some of the other issues that are in the recommendations of the report. So I did this in Maryland, and having a service integration team of cross-trained staff made a world of difference in terms of looking at measuring outcomes. So I just want to clarify that was my thinking. I tried to capture a lot of the feedback that we've been getting from all the surveys and the feedback and other sources, but I think it would deal with a lot of issues that are listed here on this page if we were to look at that as a new model for Delaware.
Okay. Thank you. Thank you. Any other thoughts about our top 10 kind of surprises, or does this feel about right with how people are thinking overall?
So this is Rich. I just wanted to mention one small thing about this. I think one of the themes that comes through these voting results is the necessity to focus on people before necessarily what kind of services they provide, and treating the whole individual and the whole patient, and not just looking at how can I provide disability services? How can I provide children's services? How can I provide this? What does the patient need? And what does that patient's particular network need? And I think that comes through this. And that was a theme that I think came through all of our division and department interviews as well. As I was one of the ones who submitted some of the options in number 10, I just wanted to say that these also follow trends for other states that are known for best practices in healthcare. So the Office of Population Health goes by very different names, but it essentially goes into proactive monitoring as well as technology integration, so that the people that are actually implementing services in other divisions can focus on implementing those decisions and not just having to do that as a secondary job responsibility. There's a certain synergy that goes by allowing people to focus on what's most necessary and to do what they do best. And I think these recommendations echo that.
Okay. Thank you for that, Richard.
Good morning, Devonna. This is Yvette. I just want to echo Richard's comments. I do believe that the voting definitely reflects a lot of the presentations and discussions that we had over a period of time. I do also agree that on number 10, with a few of those, I think that when it comes to the Latino population, I think it is could be addressed through many of these voting recommendations through inequities and racial disparities, but it's not specifically called out. And that was the only thing I think for me that was missing. And then I would certainly urge the group to consider adding some language that really speaks to that, language services to be able to reach the Latino population, because we know that those were significant barriers for that population to be served. So again, it may be implied in some of the language around disparities and inequities, but it's not specifically called out. But other than that, I think this really does reflect the discussions and the work of the group. Thank you.
Thank you. And I think you make a good point there as well. And I appreciate those comments. And I just wanted to add my thoughts too, that the recommendations as they come out, when you have 21 recommendations, you go, okay, what people really remember 10. They remember 10, they remember 5. They don't remember 21. That's one of the reasons we were trying to get at, well, what are the top 10? What are the most meaningful? But what I'm impressed with is that these recommendations do cover a range of areas. They cover structure. They also cover staffing. They also cover the actual services and how they're organized and the needs. So it hits a number of areas that, as was stated earlier, it's not just one area. It's from the lens of the consumer, what creates the most effective service delivery. And it's all of these things coming together. And of course, our recommendations reflect that in this top 10. Are there any other overall comments?
Yeah,
I would just like to, oh, go ahead, Kathy. May I just follow up with Yvette's, because I think that's important to capture. I think, you know, as we've done everything with consensus and really valuing each other's, where everyone's coming from, that not explicitly stating the Latino Hispanic population, that if you have language, Yvette, where such as Kyle had language in the Office of Health and Social Equity, and I hope that he talks to that as well. If you have language where you want us specifically to amend something, that it was more precisely stated, that if you could get that to us.
Okay. Could I just say, Susan couldn't be here this morning, but Anne, I believe I'm correct. One of her recommendations was perhaps to look at combining number 1 and number 7.
Right, and Kathy, can we hold that till we get to the next slide? Sure. We'll go through the process of going through.
Okay.
How we want to consolidate and what we want to do there. So I was just, thank you for that, trying to get in the general thoughts about these top recommendations. So I think this is a good time to move on. And Yvette, I've made a note too about the language for the recommendations. So let's just move on to our process of how we want to look at those recommendations that we listed. So there are three ways that we want to do this. One is that we want to give you an opportunity to look at all these recommendations and see, do we want to combine them? Do we want to eliminate? Do we want to add some in that are not reflected here? Or as Kathy started to mention, do we want to combine any recommendations? Do we want to eliminate any that we feel should not be included? And first of all, do you want to advocate for recommendations similar to what Bennett has done? We showed the rankings, but when we list our final recommendations, I don't think we'll have a ranking. We'll just include them, just bulleted as we had before. We can number them, but not necessarily in ranking order. So just kind of, I thought the easiest way to do this would be to go around the Zoom room and ask people for their thoughts. I did want to mention that we did have a couple of recommendations in our list of 21 that did not receive any votes. They got 0 votes, and they were the recommendation number 2 in the report, number 8, and number 13. So if you want to circle those. So let's just go around the room. Maybe we'll start off with Kathy sharing Susan Sizek's comments, because that'll help us understand what this process looks like and the kind of feedback that she provided. So Kathy?
Well, I just, you know, she suggested that number 1 and number 7 be combined. I think they speak to similar issues. And Anne, do you have in front of you the actual justification that she had? I do not have that in front of me.
I have it here.
Okay.
I have it. What she's saying is, okay. She says combine recommendations 1 and 7 to establish the new Office of Health and Social Equity in the Office of the Governor to aggressively address systemic inequities that are a result of federal, state, and local government. So she includes the whole recommendation.
Right.
And then she says, also to combine recommendations 8, 9, and 10 to address workforce issues that are negatively affect service delivery, inadequate staffing, and she writes out the full recommendations. So she doesn't really say why, what the rationale is. She's also suggesting that we combine 12 with 15 and 16. Maybe we should take these one at a time, might be easier.
Yeah, I think so. Yeah. I mean, to me, 1 and 7 does make sense to combine. I don't know how other people feel about that, but I thought that her first recommendation about 1 and 7 was appropriate.
How do you all feel about that?
I'm sorry, can you hear me? Okay. You know, I thought 7 was dealing with, I think 1 really dealt with health inequities. I think when we saw public health and we dealt with infant mortality amongst persons of color, we dealt with chronic illnesses in communities of color that have been disproportionately impacted with chronic health issues, and also COVID. It created, I saw a difference between that and then the real crux of looking at health and social services in terms of its overall leadership, where you don't have very many minorities, disproportionate small number of people in leadership positions, despite the population being served, and also in management supervision. I looked at that and more internal. So I did tease this out a little bit differently than maybe some other folks. And, you know, you wonder about diluting the mission, because, you know, I was really shocked when public health presented and teen pregnancy and infant mortality remain, like, for a 20-year historic issue in Delaware, we're above the national average.
This is Kyle. And I would like to just kind of echo Ann's thoughts on that. I agree with her, and I think some of this is a little different. We're looking into service delivery more so than anything else, and service to consumers. So I'm not sure, I'm just thinking out loud, and I'm not sure if they really should be merged together.
Yeah.
And you know what, Kyle, I want to bring up, you wanted to vote for 1 on the condition it included persons with disabilities. And yes, I definitely am very supportive of that, because well, I'm working on the Law Enforcement Accountability Task Force as well. And, you know, as you walking through the Black Lives Matter post of individuals who lost their lives at the hand of law enforcement, individuals that have suffering from mental illness, behavioral health issues, the number of individuals that are, I was just floored at that percentage and the number of individuals. And I also think persons with disabilities. So but you know, I'm also not a person of color, and I know that, or from living in a community of color. So I don't know where, you know, with that, but I would be open to including language for disabilities in there.
Well, thank you. If I could just kind of follow up on Ann's comments again on that, because just adding the word disability or discrimination, that's what I'm advocating for. And I think if you look at, you know, how all this discrimination has impacted wealth, education, employment, criminal justice, as Ann mentioned, with mental health and health disparities, they're all affected. You know, people with disabilities are all affected on those outcomes, and they're disproportionately, you know, not getting the same services consistent with people, racial, ethnic, and gender discrimination. So again, I would strongly encourage the group to include disability.
Hi, this is Yvette. I definitely agree with Kyle and Ann on those points. With regard to the staffing levels and job classification, 8 and 9 are very much, they're closely aligned. We're talking about turnover and time to fill vacancies and classifications. I mean, I think potentially that could all come under the umbrella of staffing because of the different categories. And we know that classifications and pay, and whether it's casual, seasonal, or full-time, affect the turnover in staffing. So I would propose perhaps maybe if we're looking at the staffing to maybe combine those two.
Which two recommendations?
Number 8 and 9 from a staffing perspective.
So do you mean the recommendation?
Yes.
Recommendation 8.
Yes, recommendation 8 and 9.
And I would support that wholeheartedly.
I support that too.
I'm president of the Community Resource Center, and we have been working with the state for several times now to keep a state service worker there. And there's continued turnover because there's seasonal employees with no benefits, and then they leave. And we're sending 18,000 people a year now, and sending them to Georgetown is a real challenge. So I think improving the workforce is the key to our report.
So just going back then, so that I'm not confused on what recommendation. So we're recommendation number 9, which is now ranked as 6. And where is recommendation 8? Are you referring to
staffing levels?
Yeah, it's addressing staffing levels, turnover, and timing to fill vacancies within 90 days.
Okay.
Etc. And then,
but it's not in our top. The 8 is not in the top 10. So it's
no. But I think that's a very good merger.
That makes sense. Okay, got it. I would agree with that. Could we also add to the diversity of leadership? I think that actually belongs there too. That piece of it.
Yes. I think that's a good one. Yeah, Devon, I think that's good to pull that all together.
So that's good. And I think that going back now, I'm looking at my phone with Susan's comments. I think he was asking about combining. Right, she was saying combining 8, 9, and 10.
I have looked at those. I did not see a combination for all 3, to be honest with you.
Yeah.
I worry about it bleeding too much.
I like 8 going together.
If you're not speaking, please be on mute, okay? Because everyone will have yeah, thanks. So the Devonna can then call on you.
Yeah. So we have agreement. Then it's okay to combine 8 and 9. So we're trying to move through a consensus process here.
Crystal, were you going to say something?
Thank you. Good morning. I want to piggyback off of what Devonna said about possibly adding the number 7, the disparities in the leadership, also in that 8 and 9 as well.
Okay, great. Okay. So I think thank you for that, Crystal. So I think we're good. We are good there. Can we go back to our discussion on, just so that we're clear, on number 1, we're saying recommendation number 1, we want to add disabilities. This particular recommendation the focus was on racial disparities. But if we say racial, do we want to say racial, gender, and disability disparity? And, to broaden it, to make sure that we add ethnic too. That way we have all the different categories represented that need to be a part of this.
Right. My thought was just, you have racial, ethnic, and gender, just add disability there.
Okay, great.
Thank you.
Thanks. Just wanted to make sure it's clear because I'm taking notes so that when we go back and finalize the report, that we have them appropriately. Okay. So,
and I think, Devonna, that Devonna, I think that Susan asked that it wasn't one representative of like the new office the governor formed. I guess that Sandy Johnson is head of, and I was like, no, I think this is very focused on health inequities. Isn't that correct?
Yes.
Yes. Yes. And this is the
so there isn't a similarity.
Who knows? Maybe that when this is seen or viewed, that this could potentially be a component of that, but it's intentional on our part that this be looked at because it's been, you know, eight of us thought that this was a top priority. We've seen these disparities continue on for years and years and years. So nothing's going to happen unless there's specific focus on it. Okay.
So we are not going to support that particular that a particular person be head of that, correct?
Oh,
ours are generic recommendation.
Right. Yeah, I wouldn't say that. I would just say that it could be this and that. You know, we've got the governor's looking at the racial disparities. That's one lens, but this is the lens on health delivery.
Right.
And it's important, and so maybe that's an added component that has to be considered that has not been considered yet. That's the way I would look at it.
And we are not going to support combining 1 and 7. I just wanted to be able to get back to Susan. Is that correct?
Correct, because what we're saying is that what we took the leadership component and moved that in with the workforce or staffing areas. So if we address racial disparities and equities within DHSS internally, I don't know, let's talk about that again. Is that something that belongs under the workforce, that piece of it? Does that also belong under workforce?
I think that is something that cuts across everything in our recommendations, in my opinion. I don't think it's just, you know, for one recommendation, and perhaps maybe in, you know, introductory comments that we talk about, you know, that thread of diversity, equity, inclusion cutting across everything. And so that it's implied that, you know, it cuts across everything, not just one particular recommendation. And that also includes the language piece.
So it sounds like we want to keep this as a separate recommendation still. Is that correct? I see some head nods there. Okay.
That's what I sense.
Yeah.
But one thing that we have to remember, this is Maria Matos, is that office of the governor of inclusion comes without resources. So if we pile more things on it without the resources that Sandy may need, it's really just a show.
And I was making the distinction that it wasn't part of that this is a standalone recommendation that really was health focused on health inequities and not the broad gambit, that we really want to move the dial. I think that COVID has shown us this. I think the reports from the various, from public health in particular, really highlight that. So that was where I was, that it wasn't something that would be subsumed into the other office.
That's where I was thinking that we were also.
Mm-hmm. Okay.
But we're asking number one. I didn't pick number one, but we're asking for the governor to have another person, right? Is that what number one is saying? To have an additional office of inclusion?
It's an office of health equity.
An office of health equity.
health and
Okay.
social equity, and we've amended it to add disabilities to include it's racial, ethnic, gender, and disabilities within the recommendation.
Well, I mean, if there is already an office, why don't we say that the governor needs to add additional resources so that this recommendation can be included? So that would mean that Sandy can hire staff to take care of the health inequities.
Well, at this juncture,
I'm not sure we want to tell them exactly how they need to organize it. You know, that's a little specific. I think if we put this out there, then that gives them the ability to think about how to organize it within the governor's office.
And Maria, I was thinking more along the lines that, you know, back in the day when we were doing the Family Service Cabinet Council, you know, out of the governor's office, Lisa Blunt, Rochester now, you know, we really did have a focus on equities and outcomes. And we met with the governor on infant mortality, on teen pregnancy, on these health outcomes, and that there would be an office and a focus and a linkage where health and social, you know, some of the complexities that I saw, for instance, and it's not in the top 21, but it was, you know, long-term care, the ombudsman being in the secretary's office, when in reality, it's like the fox guarding the hen house as far as I'm concerned. So having an office of equity in the governor's office focused on equity, that then DHSS for the services that they're delivering are accountable for those outcomes there. And so it created a mechanism, if you would, of oversight. That's how I was perceiving it, and a focus of a public policy priority of the highest nature, not like, well, this is something we've been addressing, you know, for 20 years.
Well, and to that end too, there is an Office of Health Equity within the Division of Public Health, has only one person in it, and doesn't really do much, doesn't have very many resources. It's not at the front line of any of this discussion, even with the COVID inequities, you know, the vaccine issue. So elevating it and giving it different. I do agree, Maria, about the resources, but we haven't really talked about resources for any of these recommendations. So I would just say overall, I kind of feel like the way Kathy does that with respect to any of these recommendations, we put them out there, and figuring out how to do it, that's really not the task of what we've been asked to do here. But this comes into what we feel is important and where the priorities ought to be.
One thing that I wanted to just kind of point out related to this is I know the initial recommendation was to put this office at the governor's level, but having looked at other states and how they structured this, they have not necessarily put the health equity at the governor's level, although some states have. They've put it either directly parallel to the office of the secretary or reporting in directly to the secretary, so that the Office of Health Equity has an equal seat at the table with public health and all of the other divisions too. And I think that's what we're kind of trying to say here, is we want it to be a priority, not an afterthought. Instead of it being something that we work on, you know, once, we want it to be something where it's not just a priority, but it has real actionable goals and a real staff. We're not necessarily trying to define the resources, but the necessity of the office and the necessity to take it seriously. If I, you know, can speak for other members of the committee based on what I'm hearing, I think that's what's coming across to me. It's not debate whether it's necessary. I think we're just getting a little bit stuck in the semantics as to where it goes. And I think the key is it just needs to be level with DHS secretary or higher, to be specific.
Go ahead, Devonna.
I was just going to suggest, what if we just eliminated in the office of the governor?
I think that's a good idea.
And that way,
Great.
Right. And that would, it goes wherever it needs to go to do what we wanted to do. Would that make sense? I see Senator Porter shaking her head. Yes. Hello there.
You hit it. Like yes, absolutely. And I also think, you know, when we're talking about resources just completely across the board, the whole reason why we are all meeting is because we're lacking resources, period, right? Whether that comes in funding, where something goes, how we move it around or don't move it around, but give the recommendations of the way the services should be delivered. Ultimately, this is coming, and I hear it even more so from my colleagues today of like, I'm so glad you're doing this task force. This is such a great thing. Hey, did you know you should be focused here? It's kind of funny that now everybody's got their own little focus point. But this is, you know, I think that removing that from the governor's office, they can decide where they want to do it. They just need to decide to do something, if not multiple things, out of the list that we're going to share. I mean, there's been great work done from the committees. It's unbelievable. This report is fantastic.
Great. Thank you for that. And Maria, does that satisfy your concern there too? I think it does.
Yes.
Okay. All right. That's the way to do it, folks. So
one down, 10 to go.
Yeah. Well, we've got a couple of other things that we were able to do too. Let me just go around the room and see if anyone else feels strongly about advocating for a recommendation that they feel either needs to be added, eliminated, or combined. And see if there's someone that I haven't heard from yet. Bennett. Okay. Yes.
Okay. Recommendation 21 about a division of aging. If you look at the demographics in Delaware, in 15 years, 35% of our population is to be over 65. I think we are positioned to begin that planning and coordination before we get to that point. So I strongly recommend we create a division of aging that's focusing just on those demographics and the needs of those clients.
I definitely felt from the presentations as well as from the survey respondents, having gone through the 491 folks that responded, 50% were DHSS employees, many of them line employees. The tax, the burden on that division to deliver and their inability to do so with consistency due to staff turnover, a lot of other issues, structural issues, too many people to serve with the resources that they have. And their mission was way too broad that I am a strong proponent of this recommendation, very, very strong. And that we really begin to, the other thing was, the other part of that recommendation, Bennett, was the combination of overlap in divisions of trying disabilities and developmental disabilities and visually impaired trying to get access. And it was, a real challenge, I think.
If I could also add, Bennett, I feel so very strongly about that. I can't tell you how many people I know just socially or whatever, who have tried to access services and have been so frustrated. There just seems to be a lack of continuity. There are too many breaks in the services that are out there for the seniors, and I feel really strongly about that particular recommendation as well.
This is Kyle,
Mm-hmm.
and thank you for all those comments. And I would agree, and I think you would get support from the disability community on separating, aging and disability. When you're looking at all, whatever we end up doing, if you're looking at a division, department of disability or whatever, you probably, for one thing, it's developmental disabilities. And I don't know if it would be division of adults with physical disabilities, and not division, but it's adults with physical disabilities. Now you have visually impaired. You would probably want to include mental health or substance abuse and mental health, because it's another division that is definitely disability related. So that would have to fit in somewhere, and you might want to include that. And I would recommend that you include substance abuse and mental health. Again, whatever we end up calling all this, you know, if it's division of disabilities, that would incorporate all those different ones. And also, when we're looking at this, I don't know, because there was another recommendation about, you know, 2 departments. So how do these fit under those if we do that? So we may just need to look at those together in some way also. And I don't know the answer to that or the recommendation, but it's just something that we might want to examine.
Thank you. Thank you for that.
I think one other comment I just want to make back on number 16, the pilot. I think that we could get some private funding if we wanted to move forward with that, with the Annie Casey Foundation and Longwood, if the state wants to pursue that. So I just want to add that to my 2 cents.
Okay. Noted.
I just want, thanks, Bennett. And Kyle, I think, you know, one of the things in respect to the public that spoke at our meetings, there were individuals that spoke about traumatic brain injury, Alzheimer's. You know, in some way, I felt like it was almost a pecking order. If if you're had milder symptoms such as dementia, getting services for those individuals or attention for those services, it didn't loom large enough. It was like, okay, you got a pair of shoes, but you don't have a hole in them yet. So come back when you get a hole in them, you know? So, and we'll address it. And I felt in some way, the public testimony was of that nature. I think irrespective of, you know, trying to figure out 2 departments, because I felt very strongly about the one proposal on the Department of Health and Social Services of beginning to look at Department of Health. The Health Department division, when they presented their size and scope and their focus, they went away from individual service delivery and more to a community-based health option, that it made sense to me that there was a human services department that was charged with the delivery of those one-on-one services and getting services to individuals. And then you had health. But on your comments, I think Richard also was of the ilk that substance abuse and mental health should also be collapsed in there. I was like, I wasn't sure about it, but I appreciate your comments.
So in looking at these, the overall recommendations, and is there a way, or could we combine the number 18 recommendation with number 21? And this is departmental-wide reorganization that considers breaking it into 2 departments and reorganizing the divisions in this way. I mean, it really is reorganization is the recommendation. That would, I mean, it's big, but is that a way for us to?
But I think it's, I think that is the recommendation. And although again, it goes back to my earlier point about people before the disability, people before whatever their diagnosis is, and being able to align people with the right services. So I mean, that's my personal opinion, is that in the way it's organized right now, it's what's known as silos in the corporate world. So as a result, you have silos where you end up having people meaning patients, going back and forth between silos. They can't get everything they need from one particular division, or the divisions don't have all the resources they need to deliver those services. I think there's a lot of synergy that could be happened by an overall structural reorg. And without one, I find it difficult for them to be able to improve the implementation of services in the existing org chart the way it is. We saw that.
This is Kyle, and I would agree with that, Richard. I mean, you not only in the corporate world, we've used the term silos in the disability world many times, and right now the overlap and the coordination between those silos is not very good.
Yeah, for example, like we heard that people who have Alzheimer's have issues getting visually impaired services. People, children have issues getting disability services. We saw that time and time again in our various departmental and division interviews. And I think that reflects an org chart or a structure that's not designed around implementing services, but more designed about a more traditional hierarchy. And I just think it needs a complete redo. I would agree.
And I think we are all trying to say the same thing. We're just not sure exactly how to say it. So, and I leave that up to some of the people in the room.
We don't want it to come off in a way where it's directed at individuals who are on the grounds every day delivering these services. This is not a criticism of those people. It's how do we make it better? I want to make sure we keep in mind, it's not about, vendettas or any of that stuff, or I want this department to be merged in because it's ineffective. They're all ineffective, and to be more effective, a more broad arching restructuring needs to happen. And I think that's what we need to emphasize.
If I could just say, in line with the conversation that's going on now, if folks could take a look at number 5, which is engage with DOE, kids, Medicaid, to serve children and youth entering adulthood. We are not doing a good job of serving the young adults who become more needy over time because they were not served appropriately at the age of transition. And I have to tell you, I feel strongly that the state of Delaware is leaving money on the table with Medicaid to serve
absolutely
many of those young adults. And I don't know if there's a way to just mention that age group in the conversation with regard to reorganization.
Well, Kathy, if we look at recommendation number 11, which is people-centered services, especially for persons in critical transitions, we could combine that possibly with recommendation 5, and that would give us emphasis on that overall area, kind of the feeder into the transition.
Right.
I think that's a good idea.
I think that's good.
I agree.
There's a lot of cross, but I just worry about not addressing that that younger adult population in a timely way, and how we wind up in the end with folks that need more intensive services and perhaps could have lived independently, but cannot because there was a lack of services. Just one example, children that in the kids department go over to DHSS at age 18 if they have disabilities, if they were in the children's mental health system, but they can continue high school until they're 21. And I'm not sure that we don't have breaks in service there.
I think that's a good.
I guess one other thing I've looked at this, I don't see that we're moving to an outcomes-based system. Regardless of the divisions that we're talking about, can we in Delaware create, what is the outcome we're trying to achieve with young children, young adults, aging, folks with disability? And I think that's going to guide the conversation more. If we can focus on what is that we're trying to achieve, the outcome measures, and then the organization will come into play, however we define it.
So,
right, and I do think there are other recommendations that relate to outcome, but I like the idea of combining 11 and 5 and the people-centered focus, and I think in that we can incorporate the outcome. I think that's excellent to include and identify that the individuals transitioning services from one department. Going back to the conversation about combining 18 and 21, I felt I felt like more that there was a benefit from having those independent because I was looking at this structurally and as legislatively, I guess, in terms of implementation, and not creating a recommendation that became such a heavy lift to get done that, such as creating 2 departments, which becomes, a long process, but creating divisions that were better aligned, and looking at alignment with Richard's focus on, it's the people less the diagnosis, and then building up to the department. So that's why I favored them being separate. But if the will of the group is to combine 18 and 21, I'm okay.
This is Crystal.
I'm fine with whatever the group decides. I was just saying that, and I'm glad we're just looking at it. So we're talking about it as when you're looking at kind of reorganization, that those 2 would need to be looked at. Whatever we think it's the best avenue to get there, that's fine.
Okay. Hello.
I have to tell you, I would not support combining the 2. I think the Department of Health and Social Services is so large. I think we benefit from clarifying some of the work for each of those organizations by separating and creating a second department.
Hi, this is Crystal. I strongly support a recommendation 21 as the Division of Aging, as the state unit of aging, who receives most of their funding from the Older Americans Act, that concentrates on the 60+ population. And with the increasing population of the older population in the state of Delaware as across the nation, I think that this should be looked at as a division of aging, as an independent division. That's just one of my recommendations.
I agree.
Okay, Kyle.
This is Kyle again. I guess I'm just asking for clarification then, because when you're, we're looking at already recommending 2 departments. That's correct, right? Department of Public Health and Department of Human Services.
Yes.
And then we're mentioning Division of Aging and Division of Disability. Are we looking though and putting those divisions under still the department in one of those 2 departments? Or are you talking about a whole different Department of Aging and a whole different Department of Disability?
No, we're talking as Division of Aging, Division of Aging.
And Division of Disability.
Right, and Division.
And they would go under the department still?
We would have.
I thought they would go. Yeah, and I was, Kyle, looking at like a Department of Public Health that was more community-based focus, and then a Department of Human Services that was more people-focused, and that the disabilities would fall under that.
Thank you for the clarification.
So just on process here, so I just want to come back to where we seem to have a little bit of a sticking point. The proposed combination of combining the 2 departments, number 18, and the creating the new divisions, number 21, into a new recommendation, which would be structural reorganization of the department, which would look at departmental restructuring, as well as creating divisions that are consumer first oriented and designated in the way they're listed here. Are we saying we don't want to do that? We don't have consensus to do that, that we want to keep these 2 recommendations separate? I see your head nods. Yes, so we're keeping them separate. Yes, just show of heads or hands would be helpful. Okay, yes, so we're keeping them separate, but we did upgrade our language though to know that we want this to be people-centered divisions, and for recommendation on 21, we're adding in substance abuse and mental health. Is that correct? we have consensus there? Yes, I see head nods. Yes, yes. Okay. Okay.
I'm the only outlier on that one, but that's okay. And but I'm not as knowledgeable as Kyle around this, so I defer to his input.
All right, just back up. So what are you saying recommend 21 is going to say now?
21 would say create a new division of aging and merge divisions of adults and disabilities, comma, visually impaired and developmental disabilities and substance abuse and mental health into.
No, I wouldn't. No, I think mental health and substance abuse is totally different than dealing with services for disability.
Okay, and others feel that way. We leave these.
Well, the reason I did is that we're, we have this opioid epidemic and mental health services. And I do feel that the intensive services of disabilities, but I don't know the rationale behind Kyle's recommendation. So, but I was one of just thinking of it being separate, just of my,
I'm not sure of the best way to do that organizationally. I do know that if you're looking at disabilities, mental health and substance abuse in some context are considered disabilities and under the ADA too, under the Americans with Disabilities Act. So I would just, if you're not going to include substance abuse and mental health, I would make that note so people are clear on that. But again, if you're talking about a division of disabilities, mental health and substance abuse are included under the federal definition.
So what if we say and consider DSAM? That way we can further examine it because I'm on the fence on it. I just think DSAM it's just so big. Then we do that, then we're back into this huge division. But I do agree with certain aspects of it, especially on the mental health and how it's classified and how it's considered under standards.
See, I believe in moving the mental health part of DSAM in aging, but I don't agree with moving the substance abuse part. To me, that needs to go under something like population health, something separate, because that's something that needs to be managed across divisions, not necessarily something. And I'm not saying that we put it in there. It could still sit in public health. But the key here is the mental health being moved so that it can be tracked, for, like we said, towards specific outcomes. And I think that's the part we're getting hung up is because it's substance abuse and mental health. I don't think anybody on the committee is debating that there needs to be mental health services as part of Department of Aging. I think it's the substance abuse. What we're saying is right now, because this DSAM is a separate unit, that means that those people who have, like I said, aging that need substance abuse and mental health have to go outside of that to get that. They can't implement it internally. I think that's the spirit behind it here. We're getting a little caught up again on current org structure and semantics.
Well, again, I think also, and that's a good point, Richard. I would think that might be an option. But we are looking at separating the division of aging and the division of disabilities.
Yes.
Yes.
So I'll just make a note.
I think I would advocate mental health and substance abuse have their own division. The interventions and the delivery systems for what we're talking about are very different for those populations. And I don't think we should combine them as like. They're very different.
So we do not have agreement at this time to combine to add DSAM into this. So I'll just say and consider mental health because I think that's where we've ended up. Let me just, again, I'm going through my notes and want to make sure on process that we are clear. We also talked about combining recommendations 5 and 11. Number 5 is not included, but Kathy had made advocated for number 5 and then Anne had agreed with that and I did as well. So Is that something that everyone would be in favor of? Okay, I see yeses. I see yeses there. Okay, good. So we'll move on there. And then we talked about moving to an outcome-based system. And I know, Richard, you've been an advocate of that, but also part of that is in number 19, recommendation number 9, to create a population health division to monitor technology integration and data analysis. Is the outcomes, is that a part of that? And would that address concerns that have already been raised about outcomes? Mm-hmm. Okay.
Yeah, and honestly, I think that also feeds into, to me, I think you could probably combine, and I don't want to start another thread, but I think you could combine number 19 and number 12, because the division of population health would be to basically aggregate all of those quality outcomes, all of the customer complaints into a single place so that you can look at it across divisions and assessing complaints and setting outcomes. So each division would set their own outcomes, and then the division of population health would measure them against those outcomes. And that's what seemed to work in other states, where you have each division sets their own goals and objectives, and then you have a separate division designed on providing qualitative and quantitative analysis towards whether they're meeting those objectives. And I think that's a big gap we saw across divisions. And I think that would kind of serve the purpose here, in my opinion.
Yes, and thank you for saying that, because I thought that as well, that those two could be combined, because they are cross-cutting across all divisions. And a lot of these in this last number 10 are kind of like that as well. So how many of you feel that that would be a way to combine the recommendations number 12, which really looks at being consistent across divisions and the gap analysis and complaints and outcomes, with the population health division recommendation?
I think I'm okay with that. Devonna, do you mind going back to your slide with all the recommendations listed on it, just so I can be familiar?
So we had some, I think everyone was in agreement of that. So I'm going back. There we go. Is that the one you want, Anne?
Yep.
Yes, that's it. Thank you. That helps. So combining number 9, what number? Oh, 19 and 12.
12 and 19. Okay, so I think
I like that.
Yeah, I think this is a good upgrade. And
yeah, I do.
Okay, so combining number 12 with 19 and that really gets at our conversation too about outcomes, making sure that that's across the board. Okay, so let's go back to, who haven't I heard from or had a chance to weigh in yet on this? Let's see, Corinthia, how about you? So are there areas that are there recommendations that you want to advocate for, or combine suggestions on combining any? We're not hearing you, Corinthia. You're on mute. Can we unmute Corinthia?
Corinthia, you're muted.
It says muted. Unmuted, but I think there's some sort of audio issue right now.
Yeah.
I think with going back and forth, Corinthia, you're muted. We can't hear you, and so I'm going. Can you hear? Nod your hair. Okay. Okay. I think that Corinthia really had focused on DHSS annual customer satisfaction survey. I know that was her number 1 priority that she and I just, is that correct, Corinthia? And I'm not sure if that can be incorporated into 12 or not, but, and Corinthia, your other ones are in there too. put up your numbers, okay, with your hand, but I think that was your big priority, correct? 2. Oh, incorporating, okay, incorporating 15 into focus on customer service and quality measures of service delivery. Combine number 10 with 15. Did I read you? Have we worked together long enough?
Combine 10 with 15. Oh,
Yeah,
okay. That makes really good sense there. Okay. So we would be combining 10 on the customer service quality and measures of service delivery with the annual satisfaction surveys. Okay. Okay. So does that makes good sense to me. How's everyone feel about combining those 2 recommendations? Okay. I see yes, thumbs up. I see thumbs up everywhere. Okay. Kyle, you good with that?
Ivana, I just have one question. In my notes that I've been going through as we've been talking, at some point we were talking about 12, 15, and 16. What did we decide with that? Accountability?
We had 12. We were combining 12 and 19.
12 and 19.
Yes, 12 and 19.
12 and 19 combined.
Right.
Okay.
And 16 combined.
So I don't know why I have 12, 15, and 16, but I don't know where I got that. Okay.
And, okay, so we're combining 10.
It's okay. You just wrote the 9 upside down. It happens to all of us.
So I think, so when we talk about all the different combinations and combining that we have, then we're only left then with number 10, which would be create a chief data officer position within DHSS. That ends up being in that. I think we're actually ending up with 10 recommendations at this point. Is there anything else that we need to do with respect to the recommendations? Are there any others that you all feel strongly about advocating for or that we need to include?
What happened to, this is Maria, what happened to recommendation 3? I don't see it here. It didn't rank?
It got 0. Oh no, wait. Recommendation 3, let's go back. I'll pull the slide. Analyzing consumer complaints. It did not end up in the top 10, but when you look at it, the recommendation, analyze consumer complaints, resolution outcomes, it's actually part of the 2 that we just combined, 10 and 15. I think it actually, in some ways, is a little bit redundant.
I agree.
Yeah, I mean, we might be able to, that would be a good one to eliminate, because we said we might eliminate a couple of these. Shall we just eliminate that one since it's in?
Eliminate the rate.
Yeah.
All right, so thanks, Maria. That's a good call. So we can eliminate number 2 from recommendations. Okay.
Eliminate number 2?
Yes.
No, it was 3.
No, it's number 3.
I'm sorry, 3.
No, not 2. 3.
3. Number 3. Sorry about that. I'm looking at it.
Good catch, Maria.
And giving the wrong number. Yes, eliminate number 3 on analyzing the consumer complaints, since it's already contained in 10 and 15, which we agreed that we would just combine. Great, good call. All right.
This is Crystal. Did we discuss number 4, the centralized wait list?
We didn't discuss it, but
okay.
No, we have. I don't think we've talked about that.
One was voted on, right? Was that voted on? Number 4? Is that in our top?
It's in our top. It's our number 4 in the ranking.
Crystal, it's in the ranking. Mm-hmm. It's there. That was your big priority, correct? Yeah, okay.
So could I just say something to that? You know, Crystal's given us better insight of what's happening where we don't have that opportunity. So I don't want us to miss that. Sorry, go ahead, Ann.
It's in there, her recommendation. Okay. We got it. It's in the top 10.
Yeah. Okay, perfect. I just want to make sure because I think that is really relevant to having a voice inside to be able to reflect where we want to move this this department.
Mm-hmm. And that was one of our top vote getters. I think 7 of us voted in favor of that. So it's at the top of our list. So it looks like we have agreement on, I don't know if it adds up to 10 where it adds up right now, but we're combining, from my notes, we've added, for recommendation number 1, we've added some language on disabilities. We also want to make sure that we add language on
gender and ethnic.
And yes, and make sure that we also have the language barriers in there. And then we've combined recommendation 8 and 9. We're also combining recommendations 5 and 11. We're combining recommendations 12 and 19. We're combining recommendations 10 and 15. And we're eliminating recommendation number 3, which wasn't part of our top 10, but in the list of 21. So now we would end up with 20, and then these different new combined recommendations. So I think
Ivana, can we look at 17? Because I see 17 didn't make it.
Okay, I'll just pull that slide up so that everyone can see it. Again, there it is. Standardizing the complaint system. And follow up and benchmarking to ensure that issues are documented and addressed. And reports should be disseminated and can be used for information to identify unmet needs for training purposes. Now, the complaints were
I don't know if that was Corinthia. I think Corinthia, that might be one of the ones that you highlighted.
Can you hear me now?
Yes.
Okay. Yes, it was. Because some had a complaint system, but a lot didn't, and they didn't provide any information on like data in regards to, you know, how they really address the complaints. So I always focus a lot on customer service, and that's part of that process, but I agree that it's important, and I apologize. I had to work on my system, but I don't know if it can be combined with, you know, 4 to me, to have a wait list is a little interesting, but you know, that's the issue to me. Thank you.
Yeah, and thanks for that too, Maria and Corinthia, because when I look at our tally sheet, it actually did get 3 votes too, which we would have added it on to this number 10 ranking, as we did with the others that got 3 votes. So if we combine that with number 4, establishing a centralized waiting list, I think that helps make a little bit more sense, and also strengthens it. So would you all be in agreement of doing that as well, as Corinthia suggested? I see head nods and thumbs up on that one.
Yeah, just one thing that I wanted to say. So the part of the population health recommendation, the office I envision, would be to not just do annual customer service, but having a customer service survey implemented by population health that then every single department can use. So then all of the feedback gets aggregated to a single place. So it addresses both the issue of those people that don't have a complaint system, and then those people who aren't analyzing the actual complaints or data coming out of those systems. So I just wanted to throw that in there too. So that would be also another expectation of population health.
Yeah, I just wanted to add and build off of what Rich just mentioned. I know in healthcare, every time we see a patient, they get a patient satisfaction survey, and it's very quick. Sometimes it's just 1 or 2 questions, but it enables the patient in real time to really get feedback about their experience and their satisfaction of services. And so while I do like the idea of having a yearly survey to determine how services are being delivered, sometimes that may be too late, and it may be so far gone that people don't even fill it out because I had services 6 months ago, you should have asked me 6 months ago, something like that. But I am a fan of real-time feedback. And if we could develop, 1 or 2 questions whereby it could be just easily shared with the patients and their families, and we can continue to build and adjust and make tweaks to service delivery throughout the year, as opposed to trying to do something after a year has passed.
I like what you're saying about real time.
Yes.
It should be transactional. It shouldn't even be daily. It should be transactional. Every interaction with the Department of Health and Human Services, you should have a survey. And
that is correct. And it really cuts across all sectors. I mean, you see it in businesses, you see it in healthcare. I mean, if you fly somewhere, they're sending you a text. How was your flight experience? If you stay in a hotel, how was your stay experience? So it's about real-time feedback because, patient satisfaction really does drive, the level of services and how they're delivered. And it also helps with, creating that 5-star delivery system.
So I have a question then based on this discussion. Would it make sense to combine, would we want to combine number 12, number 19, and number 17 and 4 all together in one recommendation? So that would be the population health with the accountability, along with the centralized waiting list and the real-time the complaint system.
Now you already have 17 with 4.
Right. So
I don't like collapsing all those into the population health. I think that's large, and I do think the focus on real-time feedback across the department and the customer service, maybe we could carve something there. I don't know. That's just my thoughts. I don't want to dump too much into one.
I think we should combine my personal opinion is we should combine 10 and 15. So, and I would just amend the language to say focus on customer service and quality measures of service delivery while conducting and aggregating real-time customer satisfaction surveys to get feedback from constituents.
We did combine 10 and 15.
They are combined. They're combined, Richard.
Combine them.
Okay, but I'm just saying we just changed the word annual to real-time and we address it.
Okay.
Oh.
Because that's what we're all talking about, right? Real-time, aggregated, comprehensive feedback that is both across divisions and separated by offices and services.
Okay, I'm good with that. I was just raising the question since several of there are overlapping, but that, to Ann's point, it does make it too big. So we're still in agreement then that we're combining 10 with 15, and recommendations we're combining 17 with 4, and we can modify the language on the combined 10 and 15 to include real time instead of the annual. So
Kyle had a comment.
Okay, Kyle.
Oh, well, thank you. I was actually agreeing with Richard. That was good language to include. That just mentioning that real time in everybody's conversation. So thank you. But I just want to make a point that I'm a real advocate of number 14. However, I understand why it would not maybe be included in this. And I think myself and maybe if NP is Senator Ford, we're probably the only ones that voted on that. But it's not necessarily a reorganizational issue. It's more of a method to provide best service delivery. So I get it. I mean, I hope the department looks into that, but again, it's not necessarily a reorganizational thing. it's a best practice. So thank you.
Kyle, I apologize too, because I used an acronym in your number 14 and I didn't spell it out for folks. And I think when people were voting, they might not be as clear. So would you please describe for everyone what 14 would do and why that was one of your top priorities?
Well, thank you. And basically HCBS pertains to home and community-based services. And there's a disproportionate amount of money that goes over for institutional and long-term care services and institutional. I think we're learning that congregate living facilities and other sorts of things aren't necessarily conducive to health. And a big push in the disability community in a long time has been increased funding for those home and community-based services. It leverages funding. It's more economical for the state. It would save a lot of money. So that's basically the reason that I put that in there, and the disability community has advocated that for a long time. Again, I realize it's not necessarily a reorganizational issue as far as departments, divisions. It's more of how those divisions implement things. And, you know, I don't know. I don't know if Senator Poore has any.
Sure. You know, Kyle, the reason why it became one of my votes is to just put it in layman's terms. You know, we moved away from the institutional way of caring for people, and we went back to a more family way of taking care of people. Maybe not family, but in other settings. I am super impressed with Stokely. I do think it's a beautiful place as an example. And I guess if I was not around for my son, you know, if I had to pick a place, I probably would pick that. Its beauty, the rolling greens that are around it, the fact that he could have physical therapy on a regular basis, occupational therapy, speech language pathologist, a doctor on site. I mean, technically you're living in an acute, maybe not an acute care setting, but subacute setting, and getting this constant care. However, it's just not something with the Olmstead Law that we are promoting. And so when you look at that type of dollars, not that I would ever change this, but my son does not get continuous PT, OT, and speech, and have a doctor literally outside our door, or any other of those services that equate to $400,000 per person. And that really, if you look at that number, is more about also the facility versus what people like myself and other family members that are taking care of their child, and or even in the smaller group homes, they're not getting that type of dollar. So it's just something that, and every family has to make a choice for themselves. They have to do what's right and best for their loved ones. So I am not making any judgments of someone needing a particular way to take care of their loved one, but at the cost of $400,000. And if you look at a number of people that are actually in Stokely, it really just is a very large amount of money.
Yeah. All right.
Thank you for that personal touch, Senator Poore.
Can I comment on that as well?
Sure, please.
This is Crystal. I'm looking at number 11 as well as 14, and speaking from an individual that's in the community working with the aging population, boots on the ground. Funding is key. If we're going to focus on this person-centered format of service delivery, increased funding in home and community-based services is very important. So I'm not sure if we looked at 11. I'm not really, whatever. Maybe we could combine this increased funding in home and community-based services with centered around person-centered service delivery.
Great point.
This is Kyle. Thank you, Crystal, for that point. And I mean, maybe again, one way to just keep that issue out there of home and community-based services is just to put it as an example, you know, implement person-centered services, especially for persons in critical transitions. And when you're transitioning, it might be transitioning into a home and community-based service. So you just put, for example, HCBS or home and community-based services.
Can I just add a personal thing? I may not have shared this with the group.
You probably, I think I might know. Is it for example?
Yeah. So
I understand that.
So I would like to propose combining the one that we already had, because I voted for the BCBS because my father, before he succumbed to lung cancer, we had to have in-home based care. And the hospice care that we actually got was absolutely incredible. And I know some people don't necessarily have, you know, the money to be able to put, and they don't want to put somebody away at home, but being able to do that at home it took 4 family members, me, my brother, my mom, and my aunt, plus the home-based care to give my father what he needed to make him comfortable. And I can say that this is one thing that no matter how much money you put into it, you will get out of it inpatient and community satisfaction. And I think we should combine, sorry, this is just hard for me to talk about. I think we should combine number 14 with the person-centered services. I think that makes a lot of sense because it really provides an example of what person-based services actually means.
So, so thank you all for the conversation. So we already combined 5 with 11. So we can add in 14 on the community-based services. And I think that
I think that's a great idea.
That helps us. So we have 5. We're combining 5, 11, and 14.
Can I ask a question? Does Delaware still have a home and community-based waiver, Senator, with Medicaid? Wow.
Yes, they do.
Wow.
It is called Diamond State Health
Plan, I believe.
Yes.
Yeah.
Thanks.
And I just want to say then thank you very much to this group. And that's why it's a pleasure working with all of you, because we talk about things, we think things out, and we come up with some type of solution that pretty much incorporates everyone's ideas. So again, thank you very much. And Richard, thank you for your personal thoughts on that too, because I get it. I did the same thing with my dad.
Yeah, I would echo those thoughts about this group, because when you look at the overall recommendations, we did have a lot of overlaps. And I know when I did the voting, it was hard to pick my 7. And I felt strongly about a couple of others, but I didn't pick them. And when we go back and we look at those full recommendations and the things that sort of got left out, we point out some things. And it's been a very helpful process. So facilitating our discussion, I'm going to move us along if it's okay with everyone. I think we went through all of the recommendations where people felt strongly. I know everyone has had a chance to weigh in, including Susan, who couldn't be here today. And we have, we've made some modifications, and one more time, I'll just go through and review them. We've made additions to recommendation number 1, adding disabilities and language on language barriers. We've also combined recommendations 8 and 9. We're combining.
Devonna, may I move you to go back to the recommendations so people can see those as you're talking?
Sure, surely.
Thank you.
So we're combining recommendations 8 and 9. We are combining recommendations 5, 11, and 14, and 5 and 11 were not included in the top 10. We combined recommendations 12 and 19, and focusing on the outcomes, making sure that we address outcomes. We're combining recommendations 10 and 15. And we've changed the language from annual surveys to real time for consumer surveys. We're eliminating recommendation number 3, which is our total list of the 21 recommendations. So we're eliminating that one. We're combining recommendation 17 with 4. 17 was not included in the top 10 list, even though it did have 3 votes, but we're combining those 2. And that's it as far as the changes. So
did you mention, I'm sorry to interrupt, did you mention combining 7 and 9? Because we said we were going to do that.
We have 8 and 9 combined.
Oh, it was 8 and 9.
We have 8 and 9.
Oh, 8 and 9. Okay,
Yeah.
what happened to number 7?
Number 7, we said we would take the leadership from that, and we would put the leadership in with 8 and 9.
Okay.
We're leaving 7 as a
7, 8, and 9. Yes.
Right. We're leaving 7 as a standalone. But
okay.
We're taking the leadership portion of that and moving that in with the 8 and 9 recommendation.
Okay, great. Thank you. Okay. Thanks for clarifying that. I just wanted to make sure. Okay.
So, so our next steps then, and this is fun. I'm glad we record these sessions. So if we lose anything, we can always go back. We will revise the recommendations based on our discussion today. I believe we do have consensus on the final recommendations. And so I had already agreed with Anne that I would work on pulling this together with our team of writers who we've been kind of working together, Kathy, Susan, and Richard. So we'll pull together these recommendations as revised for the final report, and that will be then allow us to finalize the report. There are a couple of other things that are still outstanding, such as deciding what additional appendices we would like to include on the report. And Richard has pulled together, as Anne had mentioned, the combined input from everyone into a spreadsheet. We'll probably include that, as well as perhaps some other things. He had also worked on an organizational chart that of the current organization. I think we may decide we want to include that, but so those are the next steps. Richard, Anne?
Yes, I just would like to offer, if anybody would like to work in an ad hoc capacity, that I want to express everybody, let's give Devonna a big hand for facilitating this discussion and putting the process together. Yay, Devonna. I really appreciate and grateful for your leadership there, Devonna. It was really a robust discussion. We're going to go around for the good of the order. The plan here is, as Devonna said, to get this into a final report, and to do it instead of having the whole committee, since we have consensus now on the recommendations. Anyone that wants to work on an ad hoc committee to finalize, just email me. That would be fine. And we've had folks that have already agreed to do that and have offered to do it. So if you have an interest and you want to do that, we will certainly circulate the final report to you for your stamp of approval. And any edits or final input that you might have if we've omitted something, or we failed to include something that you wanted or you felt strongly about. We have a couple things we have to go through. I'm going to go through the good of the order, and then we have to open it up to the public if there's anyone that wishes to speak. But as we go through the good of the order, I would just like people to have their closing comments. Again, I celebrate each and every one of you, your contribution and the work that you did. So if we could go around for closing comments for the good of the order.
I just want to say thank you for allowing me to be a part of this group, and it's been a pleasure, and I'm proud of the work that the group has completed.
Thank you, Yvette.
I think it's been a wonderful opportunity to learn and to meet everybody. Can Ann or someone tell me, what is the next step? Once the report is finished, where does it go and what happens?
Thank you. That was a good point. We will submit a final report of our recommendations to the full task force. And we're hopeful that we'll be able to present to that task force our findings and recommendations. I think that we have a lot of great data. We also have some background information that we are going to share with the other committees that have subcommittees and members as well. And a final report is due to be published, I think, in April. So we're looking for a meeting in March. And I hope to have all of you invited to that meeting of the full task force so that you can see their process. And I'm sure Senator Poore can talk about this.
Great, thank you.
Okay, next.
This is Kyle. And I think I've kind of said it before with that last recommendation. But again, I thank everybody for their efforts here. I truly appreciate the opportunity to work with you all. And as Bennett just said, meeting some of you for the first time. The process has been one of collaboration, respect, and I look forward to the final report and the work on the task force too, which I'm also a part of. Thank you.
Thank you, Kyle.
And I can jump in. I'll just say I agree with what everyone else has said, but this has been a really, it's an eye-opener of how important this work is that we're doing. And I just support every one of you, all of us, for the work that we're doing in this space. And it's been an honor to be a part of this group. And I just hope that this work is noticed.
Likewise. Okay, next.
I just want to thank you so much for giving me the opportunity to be part of the group. I spent 50 years working on these issues, one issue or another, and I appreciate so much having the opportunity to participate. And I'm so hopeful that folks will move forward with so many of these recommendations that have been provided by a broad array of people and could really move the state of Delaware forward in services to the community and to residents from zero to end of life. So thank you so much for the opportunity.
Thank you, Kathy.
And I just want to say, this is Maria. I just want to say thank you for the opportunity to give my little input. Thank you for your help last night. And
we got to 100% voting, Maria.
So, and thank you for putting together a truly, truly diverse group of people to tackle these issues. Thank you for that.
Thanks, Maria.
This is Crystal. I just want to say thank you for allowing me to be a part of this collaborative process. I have truly learned a lot from each one of the individuals in the committee, and I have truly enjoyed this experience.
Thank you, Crystal.
This is Corinthia. I also want to ditto what everyone said. Thank you. I grew up in health and social services, so I'm really excited about this process and realize that, you know, things do live. So this is a living process, and I'm excited about what will be. And I thank everyone for your expertise and your perspectives.
Thank you. Thanks, Corinthia. Richard?
I just want to say I'm grateful for the opportunity to be a part of this. Unlike a lot of you, I don't have deep ties to the community, but I have I'm grateful for all of you who have recognized. I just have a very unique skill set that seems to be applicable to almost every division. I want to thank all of you for gently redirecting me if for some reason I misjudged something or did not particularly understand something. This has got to be one of the most open-minded and understanding brain trusts that I've ever been a part of. And professionally and personally, this has been a great and amazing experience. And I hope I get the chance to work with you, especially Dr. Farley, Dr. Williams in the future. I'm really proud of what we've accomplished. And I hope that, like you all hope that what we've done actually resounds and leads to actual change within the department. Thanks.
Thank you, Richard. And Taylor, do you have anything?
I mean, I'll just echo what I've heard. I've been blown away by both the breadth of expertise and just the commitment to public service, and it's inspiration that I'll carry in my career. Thank you all.
Thank you, Taylor. Alexa?
I will just say that I am still fairly new to this task force and to working for Senator Poore, but since I've joined in January, I've just been, so amazed by the work that you guys are doing, and I just find it really interesting, and I've had a chance to learn a lot in such a short amount of time, so thank you.
Thank you. And I especially want to express my appreciation to Taylor, who has been so painstakingly patient, and you, Alexa, with us in this process, and so responsive and supportive for our committee to do our work. For Richard, for your incredible amount of research, and for each and every one of you to speak openly, honestly, and to share not just what you're do in your professions, but what you really truly advocate for and are passionate about. I think we have a lot to celebrate. We have a great accomplishment here, and this far exceeded, I didn't know what the heck I was getting into, but this far exceeded where I thought we would end up, and we obtained a lot of information, and I think it will be put to good use. I feel very hopeful and optimistic. So with that, I don't know if there's anybody in the public that wants to speak.
So we can now open the meeting. We can now open the meeting to the public for public comment. I do not see any attendees in the queue, but just as formality, if anyone from the public would like to provide public comment, please raise your hand. Seeing none, that closes the public comment period.
Thank you, Alexa. Do I have a motion to adjourn?
And before you adjourn.
Okay, Maria.
I just want to give a special shout out to the senator. I think she brings such leadership to Delaware. And I just wanted to make sure that we appreciate Senator Poore's commitment to public service.
Thank you, Maria. I think that's really good. And I should have, I was remiss in not recognizing that. We are all here because of her desire to see improvement. She, I think, had to jump off for another meeting. Did she? Yes, she's not here, but Alexa, you'll be sure to convey our appreciation to her for our opportunity to be a part of this task force. And we will we will be at the meeting when they convene the full task force. Okay, any other closing comments? If not, may I have a motion to adjourn? It was great working with you.
I have a question. Are you going to talk about the next meeting?
Yes, because we're not actually going to do a next meeting. We weren't sure if we were going to get to consensus here. Okay. And if we needed, so we had that as a holdover in case we weren't able to drill down. But it was it's amazing the way we've all come together work-wise, and we were able to really enrich the recommendations as they were written and do these combinations, eliminations, and advocacy. I am delighted with the process. I don't feel a need to meet. Does anyone else? I think we met more than any other subcommittee. With that, we are just going to have the ad hoc group. If anyone is interested, I'm going to remind you, just let me know if you'd like to work with the ad hoc group to put the finishing touches. You will be receiving documents. Richard has created a beautiful Excel of everybody's recommendations, and which were teased into these final recommendations. And so we will share that and other documents. We had requested from Health and Social Services a number of documents, including a new organizational chart, because since our division director presentation interviews, there have been 4 changes in leadership at the division director, as well as a new cabinet secretary. So we wanted an updated chart, and so we have some other things that we've requested, and we'll be sharing those with you ongoing. Is there any other final questions? If not, a motion to adjourn.
So moved.
Okay, second.
Second.
All in favor?
Aye.
Aye.
Thank you. Good day to everybody.
Have a good
Thank you,
weekend,
and
everyone.
Devonna,
Bye-bye.
thank you. Let's give Devonna a big hand.
Thank you. Thanks. See ya.
See ya.
Take care.
Bye.